Hello, everyone. My name is Dr. Jennifer Evan, and I'm a neurologist and headache medicine and facial pain subspecialist. Today, we're going to be talking about how do hormones affect headaches. So, our agenda for today in how do hormones affect headaches, we are going to be focusing mostly on migraine headaches. And we will be discussing the epidemiology of migraine headaches and how they can disproportionately affect some genders, like women more than men. And then we'll talk about how migraine can change through a woman's life cycle, including pregnancy, the postpartum state, lactational state, menopause, hormone replacement therapy. And we will discuss, is there any hormonal link to migraines in men as well? So let's dive in there. So we know that migraine is 2 to 3 times more prevalent in women than men. So estimates show that about 6% of the population of men are affected by migraine headache, whereas 18% of women on average are affected by migraine headache. Some estimates even have that estimate as high as 20 or 25% globally of women. So we see that it's a 3-to-1 ratio most of the time, at least 2 times more common in women than men. According to the Global Burden of Disease study in 2021, which was again represented in subsequent editions as well, migraine is the third most common disease worldwide, but it's the eighth most burdensome disease. So that means that in the United States alone, we have 35 million people affected by migraine. And again, 2/3 of that, or 3/4, up to 3/4, are women affected by migraine. And worldwide, that is over 148 million people. So it's not a rare disorder. In addition to being the third most common disease, 3% of all disability in the world's population is attributed to migraine. So when we look at disability, we look at years lost to a disease state, as well as migraine-related loss of productivity in the workplace or occupational loss of productivity. So given that women are 2 to 3 times more affected by migraine than men, we also need to look at sort of when that change happens. And what's interesting is that children, of course, can have migraine. There are pediatric headache medicine specialists, not just adult neurologists. And in children, the rates of migraine are actually quite equal until puberty. When girls start to get that hormone influence at puberty, that is when the prevalence starts to increase. And by young adulthood, we see that 2 to 3 times more prevalence in women than men. In children, 10% of school-age children experience migraine. About half of people with, as adults, have had a migraine attack by 12 years old. So we know that childhood as well as puberty are big times in the life cycle where migraine can first present itself. The peak age for migraine that affects women is between the ages of 21 and 55. That obviously correlates with the main prime of when women are doing school, education, family planning, and having children. So this is a very disabling condition that does disproportionately affect women more than men and seems to already have that hormonal influence starting from puberty. So just to real quickly review, what is migraine? How is it, a specific type of headache, or how does it differ than a tension type headache or an every other day, sort of normal headache? So migraine comes with certain criteria, and you have to have at least 5 attacks that meet these criteria. Migraines last 4 to 72 hours, so they're not a brief headache. They do come with light and sound sensitivity and or nausea. And at least 2 of the following features: they can be one-sided on the head, they have a pulsatile quality, they are moderate to severe in intensity or severity, and they are aggravated by routine physical activity. So migraine headache does take someone out of being able to function in school or work, more than just a tension type headache or a light headache would affect someone. Now, if we dive into hormone receptors in the brain, why might there be a hormonal influence to headaches or to migraines specifically? Um, Estrogen has two main receptors, the estrogen alpha and the estrogen beta receptor. And both of these estrogen receptors are found in several areas of the brain that are highly involved in pain and pain perception. So we talk about things like the trigeminal nerve, which you can see here on this diagram on the left, is a major sensory nerve that supplies pain and sensation to the face, has three branches. The trigeminal nerve is also the main nerve that is innervated in migraine attacks and propagates pain. And it also supplies sensation to the covering of the brain called the dura, as well as the arteries inside the brain. We also know that there are estrogen receptors on the hypothalamus, which is a structure in the center part of the brain, the cerebellum, which is a brain structure in the back of the brain that plays a role in balance as well as many other functions. Estrogen receptors are also found on an area of the brain called the periaqueductal gray, which is a very important structure for pain processing, as well as the cerebral cortex, which is the very top outside surface of the brain, which is where we feel or perceive pain, as well as many other sort of sensory modalities. Progesterone, which is another main hormone, is known to modulate pain. Progesterone is also metabolized into a molecule called allopregnanolone, and that molecule can enhance a neurotransmitter called GABA in the brain. So progesterone is thought to have some anti-pain qualities or anti-pain activity, given that it can modulate pain. But we do have estrogen and progesterone receptors throughout the brain itself, not just in arteries and blood vessels or organs in our body. So we know that estrogen and progesterone have the potential of affecting pain and migraine given where we find the receptors. So, the basis of how do hormones affect migraine would come when we look at the changes in hormone levels in a monthly menstrual cycle. So estrogen and progesterone are two of the main players, but there are actually other hormones involved, of course, like luteinizing hormone and gonadotropin releasing hormone. But if we take a look at just estrogen and progesterone to kind of keep things simple, we know that a monthly cycle ranges on average 28 or so days, can be a little bit longer than that in some women, up to 30, 31, or 32 days even. But if you take an average 28-day cycle, day one is labeled as the day that a period starts. And so when a period starts, your estrogen level is quite low, as well as the progesterone level. And over the subsequent next days, you start to have a slow rise in estrogen until about mid-cycle or just before mid-cycle, where you have a peak of the estrogen level, which is usually preceding ovulation or the release of an egg. Progesterone levels are still pretty low mid-cycle, but in the second half of the cycle, you see progesterone levels rise quite a bit, especially after ovulation to confirm that ovulation has occurred. Estrogen levels do remain relatively high for the second half of the cycle as you're going into that luteal phase. But then towards the end, as you're heading into the days right before a cycle is about to start, you see a precipitous dip in the estrogen level. It's that dip in the estrogen level, or that change in the estrogen level, that is quite rapid, that we think leads to the increased vulnerability that many women have in having a migraine attack in the days prior to a menstrual cycle. In our International Classification of Headache Disorders, we have two types of hormone-related migraines that are listed in the appendix. We have one that's called menstrual-related migraine, abbreviated MRM, and then we have one that's called pure menstrual migraine. Pure menstrual migraine refers to a woman having a migraine only in a menstrual association, meaning right before or during or in the first few days of a menstrual cycle. Pure menstrual migraine is quite rare. Most studies say 0.3% to less than 1% of women will have pure menstrual migraine, which means that's the only time of the month that they will have a migraine. The majority of women have menstrual-related migraine, which means up to 2/3 to 3/4 of women have some pattern of being more likely or more susceptible to have a migraine attack in the days prior to a cycle and the first few days of the cycle starting. So that's what the definition of menstrual-related migraine is. And again, it's quite common. Studies have shown that 60 to up to 75% of women have a menstrual component to their migraines. Additionally, I do want to point out that other studies have been done on migraine attacks that do occur before the cycle compared to the migraine attacks that a woman may have at other times in the menstrual cycle, because of course it is not impossible to have a migraine attack anytime during the cycle. But when you compare the migraine attacks at the end of the cycle prior to menstruation with those that are happening elsewhere in the cycle, the attacks that happen prior to menstruation, or the menstrual-related migraine attacks, tend to be more severe in pain quality. They tend to be more difficult to treat and of a longer duration. So it's also interesting to take note that when women have menstrual-related migraine, it is more difficult to treat and more severe in symptoms than their migraine attacks might be otherwise. Here is part of another study looking at menstrual migraine that was published. And again, we're looking at the changes of the hormones and the migraine attack incidence as you go through the days of the migraine of the menstrual cycle. In the top diagram, you can see women who are on hormonal contraception compared to those who have a natural cycle. And the hormones are still closely mimicking each other. And then on the bottom two pictures, you can see how migraine attacks that meet International Classification of Headache Disorder criteria, as well as menstrual migraine, do change in their prevalence or incidence of an attack in the days prior to a cycle. So again, remember, day one is the day that a menstrual cycle starts. And our highest incidence of having a menstrual migraine associated attack is in the 2 to 3 days prior to a cycle, up to the 2 to 3 days into the cycle start. So we tend to call that the -2 to +3 window. Also important to note, it's not the actual level of estrogen that triggers a migraine. They've done several studies looking at the level of estrogen between women with migraine, women who don't have migraine, the level of estrogen between attacks in women with migraine versus women who don't have menstrual-related migraine. And really, we're not seeing any change in the quantity of estrogen or the level of estrogen or the peak of estrogen. But what we are seeing, it's the rate of decline or the delta, the change in estrogen level, that seems to be the big trigger for lowering the threshold for a migraine attack to occur. So again, we call this window that a woman might be at the highest susceptibility to a migraine attack, the -2 to +3, or 2 days prior to a cycle and up to 3 days into a cycle, that they might be the most susceptible to one of these migraine attacks that are menstrual associated, that, like I mentioned earlier, can be much harder to treat and more severe. So we won't delve into treatments too much, but there are certain ways of treating menstrual-related migraine that can be discussed with your headache neurologist. Most of these are not FDA approved, but we do have several large studies that do show certain methods, like what we call triptan mini prophylaxis, which is using certain long-acting triptans, like naratriptan or frovatriptan, in anticipation of that -2 to +3 day window, or even using non-steroidals in that window can help prevent menstrual-related migraine attacks or decrease the severity. There are other methods of avoiding or minimizing menstrual-related migraine that can be considered with your provider, whether that be your headache neurologist or even sometimes your OB-GYN. or primary care doctor. And those might include low dose estrogen in a continuous fashion without a placebo week, which would essentially create a non-drop of your estrogen that normally would happen with the placebo week of an oral contraceptive tablet or with the drop in estrogen that occurs with a natural cycle. So some women do choose to be on a low dose continuous estrogen type of contraceptive. There's also extended cycle oral contraceptives and patches that, again, kind of keep your levels stable for a longer period of time, giving you fewer cycles for that estrogen to drop and that menstrual cycle to occur. Another option is something called progesterone only oral contraceptive that avoids any estrogen in the tablets. And of course, that can be a contraceptive solution by suppressing ovulation through the progesterone. But the mechanism that we think progesterone-only contraceptives can help reduce menstrual migraine is because of what we mentioned earlier, that progesterone does have that pain modulating effect and can kind of gatekeep, if you will, the effect of pain with estrogen receptors on some of those areas of the brain. So progesterone can decrease cortical excitability, which is the ability of the cortex of the brain to set off an action potential or an aura, and it can help maintain a constant low estrogen state that avoids that drop or withdrawal in estrogen that occurs right before a menstrual cycle. I will take a second to mention that there is a vascular component when we talk about hormones, whether we're talking about endogenous hormones or whether we're talking about hormones exogenously in a contraceptive tablet or other way of managing cycles or menstrual migraine. And we know that estrogen is prothrombotic, which means it increases your likelihood to have a blood clot. The important thing to know here is that a lot of studies have been done looking at women on oral contraceptive tablets, which in most cases are going to be combined tablets of estrogen or estradiol with a progesterone component. And most of these were done in the past, in the 50s, 60s, and 70s, where contraceptive tablets had a much higher dose of estrogen. There was also higher rates of smoking as well in the past than we currently see nationwide. Current oral contraceptive formulations have a much lower level of estrogen or estradiol, which ranges from 15 to 35 micrograms, whereas the older forms had up to 50 or even 70 micrograms of estrogen. And we know that there is a dose-dependent risk of blood clot, meaning the more estrogen you're exposed to, the higher your risk is of having a blood clot. And so more recent studies have been conducted in retrospective analysis on women on lower dose combination oral contraceptive tablets and lower dose estrogen exposure regimens. And we know that the risk of clot and stroke is half as high as those receiving more estrogen than those in the past. It even was the same or lower as those treated with progesterone-only methods of contraceptive. So again, you always have to consider the vascular profile or the vascular risk when we're talking about anything regarding hormones. Again, whether it's your natural hormone state or any exogenous hormone therapies that could be considered for treatment of any condition. But to avoid any estrogen and that potential risk for increased blood clot, progesterone-only formulations do exist, and we don't think those have any increased risk of blood clot or stroke. And then, with women who have migraine with aura, that's another special population that a headache neurologist will consider when we talk about menstrual-associated migraine or certain potential therapies to treat someone with menstrual-associated migraine. Women with migraine with aura, such as visual aura, do have an elevated lifetime risk of vascular events, including heart attack and stroke. And so you have to weigh that risk profile just from having migraine with aura with any consideration of oral contraceptive or hormone-related therapy you might consider for treating menstrual-related migraine. So next, we're going to talk about how women with migraine might be affected um, during other stages of their life, not just in a monthly cycle, which women, do have from puberty on, but as they approach family planning years and pregnancy. There was a large study from the American Registry of Migraine in 2020 that surveyed over 600 women and found that 1/5 of women are avoiding pregnancy due to fear of worsening migraines or consequences to the health of the baby or the fetus from having migraine condition. So that's 1/5 of women of childbearing age are delaying or choosing to avoid pregnancy because of concerns of migraine headache. And again, if we think back to how much of the population is affected by migraine, which again is 18%, sometimes upward of 20 to 25% in certain regions or global populations, that is a large number of women who are delaying pregnancy or choosing to avoid pregnancy because of fear of their medical condition, migraine headache, worsening their health or consequences to the pregnancy. This was, if you look further into the study, it shows that this is especially true in women who are younger and had fewer children. So again, that is an important feature because ability to have children and fertility does change as women get older into the higher end of that childbearing decade or age range. And so younger women are choosing to avoid or delay pregnancy because of migraine more than women on the older side of that childbearing age range. Additionally, 14% of women who were delaying or avoiding pregnancy said that they feared having migraine headache themselves would lead to a disability or malformation or other birth abnormality of the fetus, whether that was in relation to a medication they take to treat their migraine or just by having migraine, that they believed it could cause a risk to the fetus itself. So this was a pretty important study that shows us just how significant having migraine, and again, it disproportionately affects women more than men, can affect major life decisions for women as well as their families. So now we dive into migraines in pregnancy. What do we actually know data-wise? So migraine without aura is the most common form of migraine. Only 6 to 12% of women or people with migraine in general have aura. So it's much more common to have migraine without aura than it is to have migraine with aura. But if we look at those with migraine without aura, 70% of women with migraine without aura see improvement in pregnancy after the first trimester. So again, 70%, a majority of women with migraine without aura actually have improvement in their migraine frequency or severity during pregnancy after the first trimester. So the first trimester can affect women with increased headaches. Not all of those headaches are going to be migraine headaches. Some of them are going to be other types of headaches. And that's for a variety of reasons. The increased blood flow that happens during pregnancy, the increased blood volume that increases during pregnancy. And there are major increases in hormones during all of pregnancy, but particularly in the first trimester, including an increase in estrogen as well as an increase in progesterone. So the first trimester can have a higher rate of headaches in general. Again, not all of those are going to be migraines. Some could be lighter headaches or tension type headaches, if you will. Some are due to nausea and vomiting of first trimester from morning sickness, causing dehydration. Some are due to the increased blood volume that's circulating as the woman's body changes during the first trimester of pregnancy. But after the first trimester, for the remaining 2 trimesters of pregnancy, 70% of women have an improvement in their migraine frequency and severity. I will mention that several studies do show that those with migraine do have slightly higher risks of certain obstetrical conditions during pregnancy, including preeclampsia risk, which is a complex condition that relates to the blood vessels of the placenta and high blood pressure, as well as gestational hypertension, a slightly increased risk of preterm delivery. Particularly in women with migraine with aura, there seems to be more of that preeclampsia risk than women with migraine without aura. And this information on slightly elevated risks of obstetrical complications comes from, again, a very large study looking at almost 20,000 women and almost over 30,000 pregnancies. And they did adjust for other conditions that a woman might have, their physical activity, their oral contraceptive use prior to pregnancy. So we do think there is some risk for women who have a history of migraine during pregnancy, but most of these were only slight elevations. And most of the time, women with migraine have a really healthy and normal course. So going back to that American Registry of Migraine study, a large proportion of women are delaying or avoiding pregnancy because of concerns about having migraine during pregnancy. We know there are slightly elevated risks when you have migraine during pregnancy, but these are not huge and significant, and they also don't change necessarily your obstetrical care. And important to remember that migraine does improve in the vast majority of women without aura after the first trimester. I won't spend too much time on treatments, but I will briefly go over the fact that there are quite a few options for how to treat migraine in pregnancy. So part of that American Registry migraine study showed that of those who were avoiding pregnancy due to having migraine, part of those women were saying because they feared that their migraine would worsen and that they would have limited treatment options. And of course, while there are some medications and treatments that we do avoid during pregnancy, there are many treatment options that can be discussed with your headache medicine provider, your neurologist, or even your OB-GYN provider. These treatments can include medications like triptans, possibly non-steroidals, acetaminophen, of course. Caffeine can be utilized for treatment of headache and migraine in pregnancy. There are procedures, there's many supplements that are considered safe, as well as non-pharmacologic options like devices that you can discuss with your headache medicine neurologist. And of course, we always look at non-invasive treatments first, like lifestyle medication, lifestyle treatments, avoiding dehydration if you can, treating nausea, getting adequate sleep, eating small meals if you have nausea or morning sickness. So there are many ways of mitigating that slightly higher risk of having headache in the first trimester that some women do have. We know that after pregnancy, there is another change in hormone levels. So again, during pregnancy, women have a high state of estrogen as well as a high state of progesterone, which is different than the cyclical changes we see during the menstrual cycle prior to pregnancy. And of course, after pregnancy, you see a drop in estrogen levels, as well as a drop in progesterone levels. And then, of course, other hormones start to become a little bit more important. Of those hormones, oxytocin and prolactin are the big ones that we know are pretty active. Both of those hormones are involved in lactation that can occur after a pregnancy. And it's a complex relationship between the two. But in general, oxytocin does affect pain sensitivity, is found on that trigeminal nerve we discussed earlier, which is the main nerve that supplies the head and face and propagates migraine pain. And oxytocin blocks the release of CGRP, which is a newer protein in the headache and migraine world that plays a very large role in migraine attacks and that we do have targeted therapies to treat. So oxytocin prevents the release of this protein that is very involved in triggering migraine headache. Prolactin can be a little bit of a more complex picture with whether it triggers migraine or whether it modulates or decreases migraine, like oxytocin. So studies do show that prolactin levels are consistently higher in people with migraine than those without migraine. And they also may play a role in migraine chronification. So, of course, it's important to remember that even in the non-postpartum state or the non-lactational state, women and men do have both prolactin and oxytocin. Those levels are obviously going to be different than in a postpartum or lactational woman, but those hormones are not only found in the postpartum state. So we know that prolactin levels can play a role based on where they're found and how much we find in certain populations. So much so that there are studies showing that oxytocin is being looked at as a potential therapy for migraine one day because of its ability to inhibit the release of that CGRP protein. We also know that other commonly used medications to treat migraine, like acetaminophen, the triptan class, and even a medication called propranolol that is FDA approved to help prevent migraine, they all actually change prolactin levels in the body. So again, prolactin and oxytocin are showing that even in the non-postpartum state or the non-lactational state, they do and can play a role in migraine susceptibility. In one study in Canada, they looked at over 5,000 postpartum women who were breastfeeding and showed that 16% had migraine, which is pretty consistent with, again, that statistic we mentioned at the beginning, that about 18% of women nationwide and 18 to 20% of women worldwide have migraine. So in this postpartum study, 16% of the women surveyed had migraine. And the proportion of women that breastfed in either the migraine group or the non-migraine group did not differ. So we have similar rates of breastfeeding between whether you have migraine or don't have migraine. However, they did find that the odds of breastfeeding longer than 6 months was lower in the group of women with migraine compared to those without migraine. So again, we're seeing here the impact that having migraine could affect a mother's ability to breastfeed, or perhaps her duration, or perhaps her migraine treatment plan and her ability to breastfeed based on medications that she may be taking or concerned about taking while breastfeeding. So again, this really highlights the importance of both studies and knowledge about the impact of hormonal status and lactational status, but also the impact that migraine has to women. Again, I'm going to real quickly mention that there are treatment options for women who are postpartum and breastfeeding that are considered safe, just like there are options to treat migraine safely during pregnancy as well, that women can talk to their primary care doctor about, their headache medicine neurologist about, or their OB-GYN. And all of those providers should have some knowledge and ability to help you safely treat migraine during pregnancy and postpartum. And again, oxytocin may wind up being a new treatment for migraine one day. Again, even though it's this hormone that we know is involved in lactational state, but also obviously found in women and men who are not postpartum and lactating. So really quite a big role of hormones here, whether you're a woman or a man, and whether you're pregnant or postpartum. Hormones do have quite a role in migraine. So the next kind of big change in a woman's life cycle would be menopause after you have puberty and the childbearing decades. Menopause on average occurs at age 51 to 52 and is defined as 12 months without a cycle. It is well known in the literature that migraine frequency and severity worsen in the perimenopausal years. And that can be anywhere from 1 year prior to menopause to even up to 5 or more years prior to menopause. And we think that is because of the fluctuations of estrogen and progesterone that occur during the years prior to menopause, as the ovaries are producing hormones in a less stable way, as cycles change in duration, as women have longer cycles or shorter cycles because of the fluctuating hormones. We know again that drop in estrogen or the rate of drop of estrogen seems to be the biggest trigger for menstrual related migraine. And so again, all the fluctuations of the estrogen and progesterone, as well as other hormones that occur in the perimenopausal years, is thought to be why we do tend to see a worsening of migraine in the perimenopausal years for a lot of women. Additionally, not just the drop in estrogen and the fluctuations, but again, estrogen is found in all of those places of the brain we mentioned, but it also interplays with other neurotransmitters, including serotonin, dopamine levels. Serotonin is found in the trigeminal ganglia, that major nerve that creates headache pain, as well as other migraine-related molecules like PACAP or PACAP. So it really modulates and interplays with other neurotransmitters as well. So it's more than just one factor like estrogen dropping too rapidly that plays a role in why migraines can worsen around the time of menopause. So naturally, there's the question of, will hormone replacement therapy affect migraine for women if they are considering that? Two large cross-sectional studies have shown that hormone replacement therapy use was associated with an increased risk of migraine, but it was similar for hormone replacement therapy that contained just estrogen, as well as the hormone replacement therapies that were combined estrogen and progestin. Other smaller studies have suggested that the form of estrogen may play an effect, with a transdermal estrogen delivery system having more of a neutral effect on migraine in the perimenopausal years, and oral estrogen possibly having a higher increase in migraine association. And perhaps that's because of the more stable absorption of estrogen with a transdermal patch form, rather than the more fluctuating levels that can occur when you take a tablet once a day. There haven't really been too many studies looking at the effect of progesterone on migraine in the perimenopausal years. It really focuses a lot on estrogen and hormone replacement therapy. And there are, again, ways of treating this or mitigating the slightly higher risk that women have of migraine during the perimenopausal years. So that might be with combined hormonal contraceptive. That could be with other methods as well. And again, your provider will discuss with you your own risk profile, and a really personalized discussion should be had on the risks of hormone replacement therapy and exogenous hormones with vascular risks, such as heart attack or stroke that sometimes are associated with hormonal replacement therapy. Interestingly enough, there is this compound called phytoestrogens, which are naturally occurring estrogens that mimic the molecule or the molecular structure of estrogen. They call these selective estrogen receptor modulators because they do have a similar structure to estradiol, but again, they are found kind of naturally in different plants and herbs and supplements and even foods. So one open label study showed that there was a reduction in headache days by 62% when women took these two phytoestrogens, genistein and daidzen. Another randomized controlled trial, which is a pretty high quality level trial, looked at the efficacy of soy and then other substances like dong quai and black cohosh, which are other phytoestrogens, in reducing the frequency of menstrual-related migraine attacks over 24 weeks of supplementation. And it did show positive outcomes, that the soy, as well as those other phytoestrogens, did decrease the frequency of migraine compared to women who did not take those. So again, there could be a role of molecules that mimic estrogen in molecular structure. Again, confirming that hormones and their receptors do play a role in migraine for a lot of people. Lastly, we would be remiss if we ignored the fact that males do have hormones as well. We know that their levels of estrogen and progesterone are obviously not as dynamic as that in women with a menstrual cycle and with all these states such as pregnancy and postpartum. However, important to know that males, of course, do have estrogen circulating. They do have progesterone, in addition to testosterone, and they do have oxytocin and prolactin, like we mentioned. So, testosterone in general does have anti-pain effects, or what we call anti-nociceptive effects. They have done studies looking at levels of estrogen and progesterone in women and men during a migraine attack and between migraine attacks. And there hasn't been a lot of consistent correlations found between testosterone levels being lower or higher in men with or without migraine. But in women with low estrogen levels, like when they're on a oral contraceptive tablet, testosterone seems to play a role in modulating pain sensitivity. They've also looked at estrogen levels in men with and without migraine, and they have not seen any change or difference in their baseline estrogen levels in men with or without migraine. However, we do have some studies coming in recent years and decades looking at transgendered men or men who were born biologically female and then went through a transgender process to become male, and did take gender affirming hormone therapy with testosterone for that transition. And several studies have shown that in transgender men, we do see reduced headache frequency than what they had prior to the testosterone therapy for gender affirming hormone therapy. However, given the size of the studies and inability to control for other factors that can obviously play a role in migraine, it's not extremely clear or firm that there is a consensus between sex hormone balance and supplementation with testosterone or estrogen making a clear change in frequency or severity. But again, we're starting to see possible associations based on what we know these hormones do. In reality, these hormones have many, many complex pathways. So it's easy to talk about them in terms of what this hormone does, or this one tends to be anti-pain, or this one tends to be more likely to trigger pain. But there are many, feedback loops and many pathways that these hormones play a role. So quite complex in what states can affect the hormone levels and changes. Here is a list of references that I used, citing the information in the studies in this talk. And of course, any questions I'm happy to take, and please reach out to me if you have any questions. But I hope this talk was helpful in learning that there is quite a role of hormones in migraine.